The objective of this video is to perform different techniques of examination of pulmonary function, mainly your inspection and percussion. Prior to the examination, history taking was done for common or concerning symptoms, such as your chest pain, dyspnea, wheezing, cough, hemoptysis, daytime sleepiness or snoring and disordered sleep. Begin the physical examination with an initial survey of respiration and the thorax. Observe for signs of respiratory distress, such as your tachypnea, cyanosis or pallor, audible sounds of breathing, and the use of accessory muscles of respiration. Proceeding with the examination of the posterior chest, inspection is done by standing in a midline position behind the patient, noting the shape of the chest and how the chest moves, including the following such as your deformities or asymmetry in chest expansion, abnormal muscle retraction of the intercostal spaces during inspiration, most visible in the lower intercostal spaces, impaired respiratory movement on one or both sides or a unilateral lag or a delay in movement. As you palpate the chest, focus on areas of tenderness or bruising, respiratory expansion, and fremitus. To identify tender areas, carefully palpate any area where the patient reports pain or has visible lesions or bruises. Note any palpable crepitus defined as crackling or grinding sound over bones, joints, or skin, with or without pain due to air in the subcutaneous tissue. Assess any skin abnormalities such as masses or sinus tracts. To test chest expansion, place your thumbs at about the level of the 10th ribs, with your fingers loosely grasping and parallel to the lateral rib cage. As you position your hands, slide them medially just enough to raise a loose fold of skin between your thumbs over the spine.
Take a deep breath.
Ask the patient to inhale deeply.
Exhale. Inhale. Exhale. Inhale. Exhale. Okay, good.
Palpate both lungs for symmetric tactile fremitus. Fremitus refers to the palpable vibrations that are transmitted through the bronchopulmonary tree to the chest wall as the patient is speaking and is normally symmetric. Fremitus is typically more prominent in the interscapular area than in the lower lung fields and easier to detect over the right lung than the left. It disappears below the diaphragm. To detect fremitus, use either the ball or the ulnar surface of your hand to optimize the vibratory sensitivity of the bones in your hand. Ask the patient to repeat the words 99 or 111. Use both hands to palpate and compare symmetric areas of the lungs in the patterns shown in the photograph. Identify and locate any areas of increased, decreased, or absent fremitus. If fremitus is faint, ask the patient to speak more loudly or in deeper voice.
Okay, please put your hands across your shoulder and repeat after me. 99.
99.
Can you speak louder?
99.
Okay. 99.
99.
99.
99.
99.
99.
Okay, good.
Continue the examination by percussing the chest in a systematic manner, going from side to side as you move down the thorax. Percuss down the chest wall from the apices to the bases of the lungs. Listen to the intensity, pitch, and duration of your percussion notes and decide what kind of notes you are hearing. Normal lungs are resonant. Locate any areas where you hear abnormal notes.
Is it okay to put ink markings on your back?
Next is percussion to identify the level of diaphragmatic dullness and measure diaphragmatic excursion.
Sir, can you exhale all throughout, then hold it in?
Percuss downward from above the expected level of diaphragmatic dullness until dullness is definitely heard. Mark the level of full expiration.
Again, inhale and hold it in.
Next, have the patient inhale deeply and hold it in, then percuss downward to the level of dullness at full inspiration and mark it.
Okay, sir.
Then measure the distance between the expiratory and inspiratory levels of dullness. The distance is normally 5 to 6 centimeters. Continuing the physical examination into your anterior part of the thorax, all techniques of examination have been similarly done.